This video is to go over small bore feeding tube insertion. The first thing is the type of patient that would need this is one that needs GI access. That can be for medication or tube feed or free water, anything like that. The type of patient that would need this is one that maybe has failed a dysphagia screening and is possibly aspirating, or one that is sedated and cannot feed themselves. So the first thing that the APRN would need to go over is there any present GI issues such as blockage, fistula, or ileus? They also need to see if there's any skull fractures, especially those in the maxillary area. Any basilarity fractures are a hard contraindication. They also need to look at coagulation, make sure there's no uncontrolled bleeding issues. They can also look and see if there's any esophageal or transsphenoid surgeries that have been in the past. Mainly 72 hours are the big ones. Any esophageal varices are also a contraindication for this type of feeding tube. So what all will you need? First, you'll need the small bore feeding tube. We use a CoreTrack, which is a device that you can use to hook this end up, and essentially it will show exactly, you place it here and on a screen it shows exactly where it goes as you're actively placing it. This is a 10 French. There's other sizes as well if need be. You'll also need a bridle or some way to secure. Essentially what this does is it hooks into there and will actually bridle up into the sinus cavity, and you can lock your tube in. This little clip will unlock it if you need to adjust at any point. You'll also need something to check placement. KUB will be ordered, but if you need to check it right there, something that's a pH indicator. Definitely need something to help protect the skin. Cavalon is a good choice for that. You'll need some lubrication, 50 ml syringe, and a stethoscope. And as always, gloves. So what you're going to have the patient do, well, first, patient education. So you need to emphasize the need for nutrition. The patient needs to understand that nutrition is essential for wound healing and just overall well-being. You also need to let them know that it might be a little uncomfortable, but we can take breaks and we'll monitor them as needed as we go. They'll also need an x-ray at the end to ensure the placement is correct. So yes, next you'll have them sit as straight up as possible. If this is a sedated patient, just get them as upright in the bed as possible. They can tuck their chin. That will make an easier passage into the GI tract. So first you're going to measure from the tip of the nose down to the ear, and then down to the xiphoid process. Measure that length. For me, that would be roughly 43 centimeters. If you need to go post-pyloric, which is recommended, you'll go 10 to 15 centimeters past that. So the first thing you're going to do is lube up the end of your tip. If you want to check for patency first, feel free. It's always a good idea to make sure the tube's working before you put it in. So you're going to insert into the nair. Once you meet some resistance, you'll have the patient swallow. That will then help pass the tube into the GI tract. It will then go in. Once you're to the point, which mine would be 43, add the 10 to 15 centimeters. Go ahead and bridle it in. If you do have a CoreTrack, you'll be able to see a little bit easier if you're actually in, and there are certain distinctions and ways that this appears on the screen that can help you know that you've gone post-pyloric. You then remove the guide wire and save this part. Most packs come with a little baggie to ensure that the patient won't lose this part. So yeah, once you're post-pyloric, if you have trouble getting post-pyloric, you can instill some air, which will aid in expanding that pyloric sphincter, and then you can have the patient lay on their right side, and that will help the peristalsis actually get the tube to move in the post-pyloric direction. Once done, KUB is recommended so that you can ensure that the tube is where it's supposed to be. So things you want to monitor while you're doing this. One, they're going to be uncomfortable, but it's always good to monitor O2 just to make sure you haven't passed into the bronchial space instead of the GI. That will also let you a real quick indicator if the patient's in any respiratory failure from having this put in. You also want to monitor for signs of bleeding. Essentially, if there is gushing blood, that's not good, and stop and reevaluate from there. So lastly, like I said, you need to get that chest x-ray. Expected outcomes for this would be the distal end to be post-pyloric, tooth feeds being able to be initiated or medication being able to be initiated, a patent tube that's kink-free, and the patient needs to be able to swallow after this is in, so you can help facilitate them getting to the point where they can eat and drink on their own. Some unexpected outcomes for this would be extreme coughing and dysphagia, dyspnea. Once again, that's why we would monitor O2, just to make sure that they're not going into respiratory distress or that this isn't in place in the bronchial area. Pneumothorax can also occur with these. If that does happen, hard stop, and I would recommend getting a chest x-ray. If the tube is coiled in the esophageal, or if there is an esophageal tear or trauma, it's also hard stop and needs reassessment. The tube becomes dislodged, that's an unexpected outcome, or clogged. Skin irritation is also an unexpected outcome, along with possible aspiration. Post-pyloric has been seen to decrease the risk of aspiration, but it's always still a possibility. So if any of those outcomes occur, chest x-ray, especially if like you believe a pneumo has happened, or watch for bleeding, and even if there is bleeding, you need to be extra cautious that they're not aspirating the blood into their lungs. So I hope this video helped. Thanks.